Hi, good afternoon, everyone. Thank you for joining the first session in our age-friendly geriatric Tele-ECHO series on chronic disease in older adults. I know we're going to have people joining us as we continue. This series has been organized for you by UC Irvine's Division of Geriatric Medicine and Gerontology and our Geriatric Workforce Enhancement Program. Thank you so much for taking time out of your day today to join us. I see a lot of familiar faces joining us again from our previous ECHO session, so thank you for returning, and welcome to those that are new. So we have a lot to get through in this hour. I'm going to go ahead and get us started. If this is not your first ECHO series with us, then this will look familiar. This is the structure of all of our ECHO sessions, starting with announcements, introductions, followed by our 30-minute didactic. And today's topic will be focusing on prognostic considerations in geriatric medicine. And then we'll be moving on into our case presentation with collaborative discussion, followed by our closing and reminders. To make sure that the sessions run smoothly, please remember to mute yourself when you're not speaking to prevent background noise. You have been muted upon entry, so if you would like to speak up, please unmute yourself to do so. And then introduce yourself prior to talking with your name, location, and always maintain confidentiality when speaking about your clients by refraining from including any identifying information. As you all know, our CME, we are CME accredited, and our main objective for all of our age-friendly Tele-ECHO series is to educate community and rural healthcare providers in age-friendly geriatric patient care, treatment, and management, and to expand access to geriatric specialty care throughout California and beyond. And our target audience is you all and anyone with an interest in the care of older adults. So today's session is accredited for 1 CME credit, and if you attend all sessions in this series, you will receive a total of 6 CME credits. And those certificates will be sent to you by our CME office at the end of the series and will outline the total number of hours you have attended. This program is supported by HRSA, and this information or content and conclusions are those of the author and should not be construed as the official position or policy of HRSA, HHS, or the U.S. government. Usually we like to have everyone take the time to quickly introduce themselves on video, but since we have quite a few on the line, which is a great thing, we'll go ahead and have you all introduce yourself via the chat function if you can. Please list your name, your role, your site, and location. We'd love to see where everyone is joining us from today. And as you do that, we'll go ahead and have our hub team introduce themselves on video so you can get to know us. And I'll go ahead and get us started. My name is Nika Seville, and I'm the project manager for our Geriatric Workforce Enhancement Program, and we're located in Orange County, California at UC Irvine. Let's go ahead and have Dr. Gibbs introduce herself.
Hi, everyone. I'm Dr. Gibbs. I'm the Chief of Geriatrics here at the Division of Geriatric Medicine and Gerontology, and we are so happy to see everyone here. This series on chronic disease management is currently a new one for us, and we're very excited to be presenting for you. So thank you and welcome.
Thank you. And Dr. Sagal.
Welcome, everybody. I'm Sonia Sagal. I'm a clinical professor in internal medicine and geriatrics at the University of California, Irvine. Welcome.
Thank you. And Dr. Gurvich.
Hi, I'm Tanya Gurvich. I'm a clinical pharmacist. I'm a professor at USC School of Pharmacy, and my primary practice site is UCI Senior Health Center, where I help take care of our patients.
Sarah Campbell.
Hi, everyone. My name is Sarah Campbell. I am a family nurse practitioner and an assistant clinical nursing and doctor in practice. I just received my doctorate as well. So thank you for coming and look forward to sharing this discussion.
Thank you. And Carlos.
Hi, everyone. Happy Friday. My name is Carlos Garcia, and I'm the data analyst for our Geriatric Workforce Enhancement Program. Welcome.
Thank you all. Looks like we have a lot of people introducing themselves from all over, from Nebraska, UC Davis in Northern California, UCI, Indian Health Services, Oregon, Canada, all over the place. Thank you guys so much for joining us today. We'll go ahead and move on into our didactic presentation, and I'll have Dr. Sagal go ahead and get us started with our didactic on prognostic considerations in geriatric medicine. And as mentioned previously, Dr. Sagel is a clinical professor of internal medicine and geriatric medicine at UCI. Go ahead, Dr. Sagel.
Thank you so much, Nika. Good afternoon, everyone. It's my pleasure to talk with you today about prognostication. I would like for this talk to be as interactive as possible given our current Zoom format. So please don't hesitate to use the chat feature if you have a question or comment. And if you're comfortable, don't hesitate to unmute yourself and ask a question if you'd like. Next slide. Now, you might be wondering what this talk is specifically about, what we're going to focus on. And the objectives of our session today are as follows. So we're going to talk about prognostication and what it is. We'll talk about the benefits and barriers to prognostication in the clinical practice. And we're going to focus prognosis on looking specifically at life expectancy in the older adult population and how life expectancy can inform our decisions about screening assessments, lab tests, and even medication administration. And we'll talk about the concept of lag time to benefit of an intervention and how that will inform the kinds of things that a patient might benefit from. And we'll go over very briefly 3 general methods of estimating prognosis, and then I'll leave you with some tools for how best to communicate prognosis to your patients. And don't worry if you aren't familiar with the concept of prognostication. It's not something that I was introduced to in my formal training, but I learned about it a few years ago, and I think it's something that as clinicians, we all intuitively think about when caring for older adults. And it really has to do with determining an estimate of your patient's life expectancy as the measure of prognosis, which can then help to determine which screening tests are appropriate and how to determine benefit of treatment strategies. And hopefully today you'll get some concrete steps to take when thinking about prognosis with your older adult patients. Next slide. So prognostication is different than prognosis. And prognostication is actually a 2-part process. So it's the formulation of a patient's prognosis, which we do on a daily basis, and then the effective communication of that prognosis to the patient or surrogate decision maker. And you know, we as clinicians, I think, tend to think of prognosis as it relates to certain terminal conditions. So we're thinking about the prognosis of someone who has cancer or stage 4 cancer and how long they may have to live. We also think about prognosis as it relates to certain neurological conditions like ALS or Parkinson's disease and even dementia. But when we think about prognosis as it relates to the elderly, it can include, as I mentioned before, an estimation of life expectancy and even functional capacity. And developing this prognosis is an important skill that can inform patient-centered goal setting and shared decision-making. And incorporating this concept into clinical conversations will again help to determine what tests and procedures a patient may benefit from and where the risk of complications may be too great. And we want to engage in that shared decision-making conversation, and this is one tool that we can use to inform that. Next slide. So the importance of prognostication and determining prognosis. So it really helps to delineate realistic goals of care and greatly informs care decisions. It can determine whether a patient is eligible for additional services, and something that we probably all contemplate in our clinical practice would be whether someone is hospice appropriate. And that, of course, the patient has a prognosis of a life expectancy less than 6 months. Prognostication and discussions of prognosis help patients to plan better for their future. It does foster trust in the provider, even in the face of provider uncertainty. So discussing prognosis or even determining a prognosis for an older adult with multiple chronic conditions that are not, quote, considered terminal is an uncertain process, but patients do appreciate that. And Patients often wish to discuss outcomes such as functional recovery, ability to live independently, or their ability to meet a milestone to make their healthcare meaningful to them. And those milestones might be anything from attending a loved one's wedding, attending a graduation, going on a vacation that they've looked forward to. And if you're wondering about whether patients want to know and whether we might, patients may not want to know or have some anxiety around this type of conversation, there was a study done a number of years ago that looked at community dwelling older adults, and they were asked about their preference for receiving CPR and whether they would want to have that in the setting of a cardiac arrest. And after learning about their probability of survival and complications, the rate of people desiring CPR dropped from 41 to 22%. So that is sort of an extreme example, I mean, of CPR, but it does go to show that people want to be informed about their chance of survival and what a certain intervention would mean to their life. Next slide. Now, you may be familiar with the geriatric 5 M's. This is a framework that we in geriatrics use to inform our care of patients, and it involves the 5 M's, so multi-complexity, which overrides the other 4, so mind, mobility, medications, and what matters most. And having these open conversations about prognosis and meaning behind certain tests or not to do them really can inform the what matters most component of the geriatric 5 M's. And it allows us, and it allows the patients to think about their own life and what matters most to them, and if a certain test or procedure will enhance their own health goals. Next slide. Now, there is quite a bit of reluctance about prognostication from the angle of clinicians, and I certainly have faced this when I first learned about this. It's not an easy conversation to have, and I think many of us shy away from having these conversations for a lot of reasons. So we're often uncertain about how to have these conversations. We probably were not exposed in training about how to have them. We're not familiar with tools that would help facilitate these kinds of conversations. And there really is, we're now starting to see research about certain disease processes and certain lab tests to know whether there would be benefit or not. But certainly in the past, those things weren't reported as readily as we would have wanted. And we also worry that we may take hope away from patients. And again, I just want to emphasize that discussions about prognosis don't negatively impact hope or one's ability to cope with illness. And this has been looked at in research before. And patients and families often want to discuss prognosis to help with their decision-making and planning. And they are looking to us to have these conversations and be well informed. Next slide. So let's start off with a case, just to make this a little bit more concrete. So this was actually a patient that I saw in my office a number of years ago. And this is Ms. AJ. She's a 90-year-old female who came to my clinical practice site, the UC Irvine Senior Health Center, and she came with her daughter. And she had a history of some mild memory loss, and she had moved in with her daughter for this reason, and she had well-controlled hypertension. Her family history, everyone was reported to be very healthy and lived into their very senior years of 95 to 100 years of age, and they were very functional toward those years. And the reason for visit was her daughter wanted mom to have a mammogram. And so that was the case, and we sort of discussed this, but I'd like to know from you all, what would you do? What would you do with this request? And is there more information that you would have liked to have had? So maybe unmute yourself or put some information in the chat for me about what would you do in your clinic if you were faced with this? Does anyone have any thoughts?
Hi, it's Beatrice from UCI. I'd like to know why. What's the reason behind the requests for the mammogram? Is there a history of breast cancer, or is there a concern for a mass, or just understand a little bit more about why the request?
That's absolutely, Beatrice. Thank you so much for that. So really, we want to understand and put this in context for our patient and see if there's some anxiety around this request. Absolutely. So anyone have anything else?
We have a few in the chat. Somebody said, Crystal said when her last one was and why she was requesting one now. Ask if there is a history or if they have found a lump. Ask what matters to the patient, from Dr. Ross. Further conversation with daughter about what caused this request, and then what physical exam, question mark.
Absolutely. So next slide, please. So the patient had never had, so she's been getting mammograms up until this point. She had no history of HRT use, radiation to the chest, or any other sort of exogenous risks for breast cancer. She has no, her siblings, grandparents, or parents had no history of breast cancer. She did have a biopsy, a benign breast biopsy, at the age of 68. And her daughter was diagnosed with DCIS at the age of 50, and physical exam was normal. So next slide, please. So what would you do knowing this information? Would you order the mammogram? Would you defer the decision to the next visit, ask the patient daughter to think about their request and sort of see if it was in line with their health goals, or would you decline to order the mammogram? So we have our poll question up. Go ahead and submit your answer. Do we have the poll results?
Yep, those are the results. It looks like 45% have said to defer decision to next visit, ask the patient to think about the request.
All right, so 31% said they would order it, 45% said they would defer and to have the patient daughter think about this, and then 24%, a brave 24% said they would decline to order the mammogram. All right, so next slide, please, and then next slide. Next slide. All right, so let's dissect this a little bit more. So of our options, one option was to order the mammogram. This is the easiest choice, right? The daughter will be happy, she's requesting it. Studies have looked at, when physicians decline to do something a patient is requesting, how that would impact the clinician's satisfaction score. So you could be maybe assured that the daughter would rate you highly. It's probably the least time-consuming option because there's not a lot of discussion that needs to go into just ordering and following her request. But the question is there evidence to suggest that she should undergo this screening mammogram? And if she did, would there be any negative consequences to this? Deferring the decision, not a lot of discussion there. They could defer and get back to you. And then if you decline, so the brave 24% who declined to order the mammogram, how would you factually and logically present this decision to the daughter? Because this might lead to some unhappiness. And I can share with you that in my own clinical practice, the way this case played out was the daughter was fairly unhappy with our decision or our recommendation. So let's move on to the next slide. Okay, so let's talk about lag time to benefit. So one piece of information that we need to better inform ourselves and the daughter has to do with lag time to benefit, or how long does it take to show some benefit to one's health based on the tests that we're ordering. So incorporation of this concept of lag time to benefit is important when discussing decisions about possible diagnostic or therapeutic interventions, specifically and especially when the benefits are not immediate, right? And it's particularly helpful when we're thinking about screening tests such as breast or colon cancer screening. And lag time to benefit is defined as the time between the intervention and when improved health outcomes may be expected. So when discussing whether to pursue a diagnostic or therapeutic intervention, weighing the likelihood that a patient may live long enough to benefit from the proposed intervention can greatly aid clinical decision-making. So if the time that it's going to take for this patient to derive benefit from the mammogram we ordered today is longer than her life expectancy, then we really need to reconsider whether she should have the mammogram. Next slide. Now, this was an article published back in 2012, and it looked at prognostic indices for older adults. It was a systemic review. And this table, and you'll get a copy of our slides, but I think this table is really helpful. And it shows, it gives some examples of how life expectancy estimates impact clinical decision-making. And, you know, one area that we are now thinking about this more and more has to do with diabetes as an example. So we now know that there's limited benefit to lowering A1C to a target of less than 8 if the patient's life expectancy is less than 5 years. So we're really, you know, do we really need to get someone to an A1C of 6.5 if their life expectancy is less than 5 years? And if we try to do that, maybe the risk of hypoglycemia is great and can be life limiting. Maybe there would be some discomfort and unhappiness with having to prick your finger multiple times or take more medications than one desires. So the intervention may not have the impact that we're looking for. We also know more and more now that tight glycemic control is unlikely to prevent microvascular complications in people with a life expectancy less than 8 to 10 years. And that's really why we've loosened up some of the A1C targets for people. And so this is a great table to have at when you're in clinic to look at some of the kinds of interventions that we might propose for someone in relation to their life expectancy. And the same can be looked at for breast cancer and colon cancer screening. Go ahead to the next slide. So if someone has less than 5 or 10 years of life expectancy, maybe the colon and breast cancer screening, the lag time to benefit is greater than their life expectancy. And I think this table is interesting because it shows also for some things like SSRIs. So you might wonder, well, how long is it going to take for someone to have benefit from an SSRI? So 1 to 2 months. So even if your patient is on hospice, certainly their life expectancy is less than 6 months, but I would not hold an SSRI or those types of medications should they need it. It also, you know, we, in our office with our clinical pharmacist, Dr. Tatiana Gurvich, we have lots of conversations about statin use in the older adult and whether lag time to benefit is meaningful for primary or secondary prevention using statin drugs. Dr. Gurvich and I will be presenting at a later seminar during this series on osteoporosis. And interestingly, I found that the lag time to benefit for bisphosphonate therapy in someone who has osteoporosis is 8 months. So it's a lot shorter than I would have anticipated. Next slide. Okay, so if we think back to our patient and the daughter who are requesting this mammogram, it's important for us to take her life expectancy in context, and that's going to be our marker for overall prognosis. And you know, life expectancy is significantly impacted by where we live. Factors that impact life expectancy include gender, genetics, access to healthcare, hygiene, diet, nutrition, exercise, lifestyle, crime rates, all kinds of things. But I thought it would be interesting to just see. So, put in the chat for me, what country or region you think has the highest life expectancy, and what region has the lowest life expectancy?
Seems like a lot of people know that or are saying that the highest is in Japan.
All right, next slide. Next slide. All right, so region or country with the highest life expectancy, you guys are right on. So Japan, really, if we think of country, would be number one. As a region, it's Hong Kong. Their overall life expectancy is 85 years. Females live to average 88 and men to 82. Then Japan, Macau, Switzerland, Singapore, Italy, and so on. And next slide. So the lowest life expectancy, as you can imagine, we are looking at several African nations for all the reasons that you would expect. Next slide. Where's the United States in all of this? We rank number 46. In terms of life expectancy, our average life expectancy for both men and women is 79. Females tend to live to 81, that's the average, and then men to 76. And interestingly, here in the US, we are behind Canada, Cuba, Malta, Martinique, and most of Europe. So again, where you live significantly impacts your life expectancy. Next slide. Now, general life expectancy data is helpful to a point. So if you know that the average age for females in the US is 79, that's helpful to a point, but there has to be a better and more methodical way to prognosticate for our older adults. And there are three ways we can do this. Clinical judgment, which we do every single day, life tables, and prognostic indices. And we'll talk about these in some detail. So next slide. Let's talk about clinical judgment first. So this is something that we do every day. So with time, we build a set of anecdotal cases that shape our estimation of prognosis. And we weigh our experience with the patient's previous pathological and clinical findings, diagnoses, comorbidities, and this shapes our judgment on what the prognosis is for a patient. And interestingly, this has been looked at in research, and it has found that as clinicians, we're not so accurate, and our prognosis, or our ability to determine prognosis, is significantly influenced by relationships. So the longer you have been someone's provider or clinician, the odds of making an erroneous prediction go up, and we tend to overestimate someone's longevity. Next slide. So we really need a better way. So, clinical judgment will take us so far. So we can use life expectancy tables, so the average life expectancy tables, and we can give us a broad estimate of median survival for a general population. And while these provide a more data-driven starting point to estimate prognosis, you all know that there's significant heterogeneity among older adults. And so an 80-year-old may be wheelchair-bound, and an 80-year-old might be climbing Mount Everest. So significant difference in function. And to account for this, we can use tables that separate life expectancy into quartiles, and then use our clinical judgment to decide whether an individual is in the healthiest quartile, in the sort of average quartile, or the least healthy. So next slide. And this is just an example of a life expectancy table, just sort of a general table. And it goes to show the point that if you're a 80-year-old female, you have a 50-50 chance of making it to 90. So you don't know, using this type of an estimate, you don't know whether your patient's going to fall above or below that average. Next slide. So something a little bit more specific would be to break down one's health into quartiles. And so you can see that this type of a graph, so for someone who's 80 years of age, or an 80-year-old female, the lowest, sort of the least healthy group would have maybe an average life expectancy of 5 years. The median or the mean group may approaching 10. And if you're in the top 25th percentile for health of 80-year-olds, you're going to maybe have a life expectancy that even exceeds that 10-year mark. Next slide. And you can find this information in a table that looks like this. So this is average life expectancy based on quartiles, overall general health. Next slide. All right. So you can use a table like that and you're going to get a little bit more accurate, but it's hard to know whether your patient is sort of average health or very healthy, or what constitutes sort of the least healthy group. And there are indices that can help us to delineate this even further. So so depending on the type of illness that you're looking at, and we tend to think of prognosis when we think of malignancies, and there are lots of published studies that for a particular kind of cancer with a particular kind of pathologic or hormonal feature can give you very specific data about how someone will do over time. But for our older adult population, that's a lot more difficult. It's very difficult to do that because we have such variation in functional status and comorbidities. And so we're really looking for tools that will take this into consideration. We'll take function and age and comorbid conditions into consideration and give us a more realistic and accurate picture. So next slide. All right, so these are just 4 examples of prognostic indices that you can use. Personally, it's very time consuming and difficult to go and find these, but thankfully, folks at UCSF have put together a pretty user-friendly tool that we can use that incorporates a lot of these prognostic indices and models, and will help us come up with a way to assess our patient. So next slide. All right, so before, so younger folks, people that have a cancer as a one predominant diagnosis, they generally have a clearer trajectory. And there may be strong value in disease-specific prognostication, but because of the heterogeneity involved in our older adults, and the lack of one single dominant medical issue, it's much more challenging to find the one article or the one value that we can use to extrapolate this. So we have to take into consideration age, function, cognition, and multimorbidity. Next slide. And so I guess the point I'm trying to make here is that generally this information is hard to come by. And so we have tools that will put together the patient's, all of these 3 factors, so multimorbidity, function, and cognition, and give us a way to estimate this information. And, it's interesting when you look at medical education, of our medical textbooks and our clinical textbooks, we focus so heavily on etiology, diagnosis, and treatment. I mean, every chapter on every disease definitely has those 3 sections, but there isn't usually a 4th section that talks about prognosis. And, one could make the argument, certainly in geriatrics, that we need to have more focus on that. Next slide. All right. So, prognostic indices, these are validated tools that we use to evaluate one's characteristics from a particular population and come up with a prognostic estimate. And the tool that I think is most user-friendly and very quick to implement in a very busy clinical practice would be ePrognosis. And I wanted to just walk you through a few slides about what ePrognosis looks like. So next slide. And these are just some screenshots of ePrognosis, and you can type in eprognosis.ucsf.edu or ePrognosis UCSF in your preferred search engine, and you will come to this diagnosis. And ePrognosis has the calculators and the tools there for you. You can calculate one's life expectancy. You can also get information about whether your patient would benefit from cancer screening, particularly breast or colon cancer. And the nice thing about this tool is it also has videos and tips for how to communicate this information to your patient. So next slide. So as we talked about before, there are so many factors that influence one's life expectancy. And so this tool will have you go through where their living environment. So someone's life expectancy who's in hospice or a nursing home versus being community dwelling are very different. So this tool does assess that. Next slide. It assesses where they live, because we know where someone lives has a huge impact on longevity. Next slide. Talks about how long someone has had the clinical issue in question. Next slide. Talks about their age. And then it has you go through a series of questions that look at whether what their overall health is, if they've ever had a cancer, congestive heart failure, diabetes, if they're a smoker. Next slide. What their physical status might be. Talks about whether they've been hospitalized, if they have any memory issues. And then it also talks about issues with bathing, dressing, so ADLs and IADLs. And then you can calculate your patient's risk and get some information based on that. And then also, again, if you go through the same screens, you can get an estimate for cancer screening. So it's very quick, less than 2 minutes to input your patient's information. So next slide. So if we go back to our patient, right, who wanted the mammogram, and she was a 90-year-old female, so we input that. She had some memory issues, we input that. She had high blood pressure, her age, and we, next slide, got some information about whether we should order the mammogram or not. And in fact, given our patient's function and medical history and age, the recommendation was that screening for breast cancer is more likely to cause harm in this patient than help them. And screening would generally not be recommended. Next slide. The tool then goes on to tell you why this might be. So the tool tells you that of 1,000 people, like this person who got tested for breast cancer, 100 people will experience harm in the first year. One person, so after 10 years, only one person would avoid death from breast cancer. So that's pretty low. And 600 people, like our patient, would die, would pass away, whether they got tested for breast cancer or not. Next slide. And to facilitate the conversation about whether your patient should undergo mammogram or breast cancer screening, it does give you some tools that are specific to the patient. So, what are the benefits and what are the harms? And you might be wondering, like, it's a mammogram, so, how harmful could that be? But it is uncomfortable, and it can cause some anxiety. Some patients will have a false alarm and maybe require additional testing or even a biopsy, which can again cause pain, harm. Maybe there's some risk of infection, and it's very possible that even if there was a small lesion, given our patient's life expectancy, it would not ever have caused a clinical problem for the patient, but it would cause significant pain if she were to undergo treatment for that. Next slide. Sorry, okay, there, sorry. So you might be wondering, so what is her life expectancy? So our ePrognosis calculator, given our patient's information, gave us a life expectancy of between 5 and 7.2 years. So very helpful. And you might be asking yourself, do patients really want to know what their life expectancy is? And I'm not necessarily saying here your life expectancy is 5 years, but we're going to talk about her health in the context of her remaining longevity. And there was a study done, it was published in JAGS in 2003, that looked at whether a patient wanted to know, whether a family member wanted to know the prognosis of a particular patient. And patients, 55% wanted to know. Only 5% said that they didn't know whether they wanted to know or not. And for caregivers, 75% said they wanted to know what someone's prognosis was. And when asked, they said that they wanted to talk to their doctor or their clinician about their prognosis. So 75% of people said they definitely wanted to have that conversation. And the reasons why they wanted to have the conversation were to prepare, so logistically and financially, psychologically and spiritually, to prepare family and friends, to make the most of the time that they have left, and to be sure that they were a participant in any medical or health related decisions that they could resolve while they were well. So next slide. So very briefly, in terms of communicating prognosis to your patients, it's really important that we make well-informed estimates of prognosis using validated tools so that we can have these conversations with confidence. And we discuss them in terms of this context of lag time to benefit. And while having these conversations, we really want to assess one's knowledge, expectations, and readiness. We want to provide this information in coherent, manageable quantities and maybe over multiple visits. We want to support patients and their surrogates and develop a shared plan for next steps. And our time is limited. We have a very brief presentation period, but in the slide deck that you'll get, there are several slides that talk about how you can have this conversation with patients in a meaningful way. And I hope you'll have an opportunity to take a look at that. So basically, in summary, I think, and I'm going to sort of end the talk here to have time for our case, but in summary, prognostication includes both a prediction and communication of the probability that a particular outcome will develop in an individual over time. And using the lag time to benefit is very important for guiding shared decision-making, whether it has to do with medications, screening tools, screening tests, and other interventions. And we can estimate prognosis using our clinical judgment, age-based life expectancy tables, published studies, and then a prognostic indices such as Prognosis. And then there's some slides about the spikes mnemonic, which can assist in the delivery of difficult news. So to summarize our patient case, we did have this conversation with the daughter. She was initially very upset and felt that we were denying her mother a mammogram, which is a much needed tool. And most likely she was interested in having this mammogram as she had a DCIS diagnosis herself. But after much conversation and an understanding of the negative consequences that her mother could undergo should she have a mammogram, the daughter was very understanding of the situation and actually declined the mammogram herself. So thank you very much. I'm going to end it here.